Please welcome your moderator, Economist Group's Senior Editor, Matthew Bishop.
Well, good afternoon. Hope you had a good lunch. Our job is to stop you from falling asleep. Hopefully we're going to do this. We have a lively panel of experts to discuss really the implications of the new Sustainable Development Goals that have been agreed by most of the governments of the world last September at the UN General Assembly, which really challenged the world to raise its performance on a whole variety of measures, of which health and wellness is a key part. And we're going to look at what, in practice, that new framework means, what we need to do to deliver it if we are taking it seriously. I'm going to start, I'll introduce the panelists, and I'm going to take you quickly through some slides to set the context. So to my right and your left is Stefano Bertozzi, who's Dean, School of Public Health at the University of California, Berkeley. Next to him is Deborah Birx, Ambassador at Large, US Global AIDS Coordinator and Special Representative for Global Health Diplomacy at the State Department. To my immediate left is Shea, who's CEO of Aeras, and next to her on the corporate side of the debate is David Barash, who is Chief Medical Officer and Executive Director, Global Health Portfolio and GE Foundation. I want to start by calling up slide number 46, which is trying to set some context for what we're talking about this morning. Chart number 46, which should be, so I was involved in founding something called the Social Progress Index with Professor Michael Porter at Harvard Business School. And the aim of this is to provide a non-economic or non-financial sense of how countries and the world are doing in delivering progress to their society. And it's, as you can see, it has three basic pillars: basic human needs, foundations of well-being, and opportunity. And each of those three pillars has four components. And health, in particular, features in the basic human needs section, where we look at nutrition and basic medical care, and in the foundations of well-being section, where we look at health and wellness, measures like life expectancy, premature deaths from non-communicable diseases, obesity, etc. This highly correlates with the SDGs, although there are only, 12 categories in the Social Progress Index, and there's 17 goals and 169 targets for the Sustainable Development Goals. This highly correlates. And the next slide, slide number 47, tells you quite an interesting story. If you look at the index as a whole, compared to GDP per capita, we see quite a wide range of performance in terms of some countries. If you take New Zealand up at the top there, or indeed USA and Norway, they deliver more social progress per cap for each unit of GDP per capita than the average frontier that you see represented by the curve. You see some countries doing a horrible job in delivering social progress. So Russia, Kuwait, China, and India are all below the curve. Next slide, 48. If you look at the world as a whole, the average score on social progress that we find is 61 out of 100. But if you look at the different components of the index, on some measures, the results are much better for the world as a whole. So in particular, the world is gets a pretty high score, well up into the high 80s out of 100 on coverage of nutrition and basic medical care, and reasonably well, certainly above 61, low 60s on the health and wellness measure. So the very basic stuff we're doing relatively well compared to other measures of social progress. The higher, in more developed economies, which tend to be where you see the need for progress on health and wellness to be a higher priority than some of the more basic stuff, because the basic stuff is already being done, more close to the average. If we go to the next slide, to achieve the global goals, we looked at the correlation between social progress and per capita GDP, and then looked at the US government's central economic forecast for each country in the world through to 2030, and tried to extrapolate from that what if we hit the forecast goals and maintain current relationships between the various components of social progress and GDP, we will by 2030 move the world from 61 to 62.4. So current policy doesn't get us very far. To actually achieve the goals, we need to get somewhere up into the mid-70s, which if the next slide, slide 50 comes up, basically to get there, if we simply improve the underperforming countries to get them to the average, we get to about 65. If we improve every country by the same amount that we would be improving the underperformers, we get to about 67. So to get anywhere near the global goals, we need to get a significant improvement in the effectiveness of policy across every component of what makes for social progress. And what's been very interesting, I think, about this whole process of sustainable development goals is it's bringing in the developed countries as well as the developing ones and highlighting how they also need to make significant improvements. This is not just about what's happening in the poorer parts of the world, it's about what's happening here as well. The last two slides, slide 51, if we look at the basic nutrition and basic medical care, even though that did pretty well globally, we can see there are a number of countries, none of them terribly surprising, that are below the curve in terms of what we would expect on per capita. But the USA is actually significantly below the curve and not a great deal better than Saudi Arabia. And if we go to slide 52 on health and wellness, again, a lot of countries are massively underperforming compared to what you would expect for their per capita GDP. And again, USA slightly below where you would expect it to be. So all these countries below the line in both those last two slides are obvious areas, it seems to me, for investment to achieve the SDGs, because there we can merely just move them up to what the line would be and we get massive global benefit. But I wanted to turn to each of our panelists and get their sense of where the priorities ought to be, how we particularly mobilize finances towards the areas of top priority, because there's particularly a reliance on a lot of private money if these goals are going to be met, being invested in achieving better health outcomes. And I wanted to start with Ambassador Birx, because I think you've basically been at the coalface of health diplomacy and of looking at the HIV/AIDS situation globally. I mean, I want to get a sense from you of what difference does this new Sustainable Development Goal framework make to you compared to where we were before with the Millennium Development Goals, and where do you see the most urgent priorities?
Great. I love the way you talk about you can't do business as usual. If we could just put up slide 39, and I won't show anything but slide 39. It's a very, I think this really gets to the crux of the HIV/AIDS problem. We've made tremendous progress in preventing mother-to-child transmission. So in every country where we work, we're over a 60% decline, and you heard from the lunch how much impact we've had in pediatric new infections. But if you look in that absolute where you are and you look carefully at all of your data, you realize at the time we made progress in getting to pregnant women and preventing them infecting their child, and through the breastfeeding period, through ART, through treatment, and then you say, how have we done with adult new infections? And we've had less than a 15% impact on adult new infections. So this whole sense of success was largely being disproportionately driven by the success of the maternal child health block. The other thing, we didn't prepare for success of the MDGs. So I hope we prepare for success of the SDGs. And what do I mean by that? We had these great goals of improving under 5 survival, and we did as a global community dramatically. But we didn't plan on having 40% more adolescents. When you saw that slide at lunch, that said the average age in Uganda is 15. This is all through sub-Saharan Africa, where we also talked about it being 2/3 of the HIV/AIDS pandemic. And I just told you we haven't changed adult new infections. And now we have 40% more adolescents because of the excess of the MDGs, approaching the most vulnerable at-risk group for HIV infection, particularly young women. And so the SDGs gives us a new framework, and this is just our DREAMS intervention. That stands for Determined, Resilient, Empowered, AIDS-Free, Mentored, and Safe Young Women. And this is very much focused on bringing together that gender equality piece, bringing together the education piece, all focused in a multidimensional way, multi-sectoral way, to actually end the HIV/AIDS pandemic.
Do you think that this very strong performance that we've actually seen on the basic health measures in the last 15 years, is that somewhat misleading in terms of we were getting the low-hanging fruit and now we're moving into the much more difficult challenges?
No, it says when we focus, we can achieve greatness. So we were focused on proving under 5 survival. So all of our investments were within the maternal child health blocks in the low and low middle income countries, which was great. So we improved maternal mortality, we improved under 5 survival, but if you're over 5 and you're female, or if you're a male, there isn't a binding site within the wellness health promotion framework. So we talk about it as building a health system for the 21st century, not the health system for the 20th century, which served us very well collectively. But if we're going to achieve what you talked about with wellness and the economic growth that was mentioned at lunch, we're going to have to do things differently because we don't even have a system to deal with adolescents or men within the context of health and wellness.
Now, Stefano, is this new framework helpful? Has it got the right things there for us to focus on?
I think it's very compelling. I'll give an example. If you'll pull up slide 26 for me. I think what's different from the approach Debbie is taking, from the one that you were illustrating with your curves, is the level of granularity. So what you were showing.
We got slide 26, please.
Yeah. What you were showing in your curves was a dot per country. To start with, it's really easy. That's not 26, I don't think. It's really easy when you're looking, there we go. It's really easy when you're looking at your dots to think that each dot is similar. One dot is like another dot. But in fact, Guatemala's up there and so is India up there. So the state of Bihar in India is roughly speaking the size of Mexico. Mexico is a big country with 120 million people. So it's really difficult to know, first of all, to keep that relative scale in balance when you're looking at that. But more importantly, Bihar doesn't have a manager, right? So if you're looking at variations in performance, it's helpful to look at it across countries because it gives you an idea of what's possible at a country level. But it's only really relevant from a management perspective for those levers that you flip at a country level, which might be, for example, national civil service regulations or things like that. But most management decisions are made at a much more granular level. So here's an example from Mexico. This is the performance of the clinics that deliver, in the public sector, the Ministry of Health clinics that deliver antiretroviral therapy to people with HIV. And this bar chart is all of the clinics, 1 bar per clinic, showing you the variability in the proportion of patients in that clinic that started therapy above a CD4 count of 200, which is the absolute bare minimum at which you should be starting. I mean, you should be starting over 500. This is, and you can see it goes from less than 25% to 75%. So within Mexico, huge variability in terms of different clinics' ability to get out into the community and get people started on time, right? If you click forward to the next slide, you can see the same thing, but the performance of the clinics with respect to whether they're able to keep the virus at an undetectable level. How are they doing for those patients that get into the clinic at treating them? So when you get information at this level of disaggregation and you show the clinics, I'm such a strong believer in the power of sunlight. And I think what a lot of the work that Debbie has done has been by revealing the heterogeneity to the people who actually implement and showing where somebody is relative to somebody else at the level where management decisions are made. It creates very different changes in behavior. And I think that the kind of progress that you were looking for in your initial introduction comes about not just by holding countries accountable, because we saw a lot of progress on that through the MDGs, But within countries, it comes from revealing the data at the level the decisions are actually made.
No, as I understand it, that's not what's being put in place. So how do we make sure that happens?
There's been huge progress in Debbie's time at PEPFAR in moving in that direction, but this information is not available for the United States. I can't show you this graph for the United States. You can't imagine Howard Schultz, the CEO of Starbucks, not knowing what the sales are, what the revenue is for every single individual Starbucks, right? How is it possible we don't know this at the level of individual units of service provision in our health systems all over the world? So it's trying to get, it's not that we want to treat these places as if they were the private sector. We want to bring modern management practices, which have diffused in the private sector, into the public sector.
Now, how do you think we do that? I mean, given where we're starting from here.
By starting to put sunlight, just like this. I mean, I can show you I do a lot of work in Mexico. I have other slides to show you the clinic by clinic, the proportion of diabetic patients who are controlled in diabetes. This is the first time we've even remotely had that kind of data at this level of granularity. So the question is, how do you build the relationship between the folks who have the data, the incredible availability now of data, and the desire to be transparent about it?
I mean, because one of the problems that has been identified with the Millennium Development Goals is that, actually a lot of the data wasn't properly tracked. There was a lot of reliance on self-reporting of variable quality, of modeling and so forth. And there's a general, reluctance to invest in data collection of this kind of excellence. And how do we overcome that?
My answer to that is that if you're relying on people reporting data which is just moving up and aggregating, you know already it will be bad quality. If it's data that are being used to help you as a manager manage better, because it feeds right back to you, then if your data are bad this year, they'll be better next year. And if you're an outlier this year and somebody worries about it and pays attention to it, it'll be better next year. So I think if data are not useful at the level at which they're produced, then you're not going to get good data.
Did you want to emphasize something there?
Yeah, no, so that's what we've done over the last 2 years. We have data now down to the site level that is shared. And the issue is sharing and visibility, because it doesn't help to have all this data unless it's visible like this. Excel spreadsheets don't make data exciting, but geospatial mapping and volume makes data exciting and real and makes it clear that there's an individual behind that. And so we've been putting more and more of our data up online. That does open you up to criticism, but you have to be willing to open yourself up to criticism, to have that kind of sharing that we all can participate in, so that you can go in and say, where are the 5,000 PEPFAR sites in Uganda, and how can we graph on hypertension and hypertension control and bring that data into line with this data? Because you're absolutely right. We can't expect to handle the SDGs like the MDGs and have the outcome that we need for the SDGs.
So, I mean, one of the big differences with the SDG process compared to the MDGs is that there's, embedded from the start a recognition that the private sector has to play a significant role. And I wanted to turn to Jackie and David and get a sense of where you see, firstly, I mean, Jackie, the scope for medical innovation to play a big part. How necessary is that going to be if we're going to achieve the goals, and how are we going to get the innovation we need? I mean, you're in the vaccine sector, which has been an area which has been horribly underfunded from an innovation process for many years.
Absolutely. And if we just go to slide 3, if I could have slide 3 up. I think I completely agree with Debbie and Stefano that having the data, understanding the data, and really sort of putting in place the interventions that the data suggest are going to be critically important. However, in TB, I think business as usual is not going to work for us. It's pretty clear based on our current tools, our current approaches, while we'll make incremental improvements, we're not going to be able to reach the SDG goals of eliminating TB by 2030. We're over 1,000-fold higher than the level we need to reach, and we've got a very short period of time to do that. So really, what we need are new tools. We need new drugs. We need new diagnostics. We need new vaccines. One set of tools by themselves is not going to do it. We need to have a combined approach. And this is really where industry is so important, because it's not just the vaccine companies, it's also the drug companies, the diagnostic companies. And how do we get them to work, particularly in the vaccine area, in an area which has high opportunity cost for them, low returns? We can talk about the TB vaccine pipeline later on, but we have a pretty broad range of candidates in different stages of development. We're not able to move them forward because we're having to do things sequentially rather than in parallel because we don't have the resources.
So by sequentially, you mean just one drug at a time? Or?
One drug at a time, because the majority of our funders, they don't have the resources to back several candidates in parallel. We haven't got the multinational pharma companies investing, and therefore we don't really have the resources to take things forward in parallel. TB, last year the global investment, or actually 2014, the global investment in TB vaccines was just over $100 million. It's just not enough.
And as you look at other areas where vaccines are needed, or indeed other sorts of drugs, what are you seeing a similar picture, or is there no generalization that can be made?
I think what we are seeing with the consolidation of the vaccine industry, we're having less and less players interested in global health. I think these programs are immensely technically challenging. They're resource intensive. Certainly in TB, we perhaps haven't done as good a job as we should have in terms of advocating for new TB vaccines and getting the global community together and making the best use of our data to advocate for vaccines. So that there's an awful lot to do. And we have a window of opportunity now. We have MDR TB, we have XDR TB. We don't act now, if we don't make the long-term investment in a vaccine, we're going to be in a very bad situation in 5-10 years' time.
And you have this.
I just wanted to follow up and ask, why do you think that middle-income countries, in particular China and India with their huge burdens, aren't investing more in TB vaccines?
So I think it's partly a technology gap. I mean, vaccine science is difficult and challenging with TB. We have a partially efficacious vaccine, BCG, which protects infants, but we've had that vaccine for nearly 100 years, and we still don't know how much it protects, and when it does protect, why it protects. It is tough and challenging science. But on the other hand, the fact that we have a partially efficacious vaccine gives us hope that it's achievable and that we can improve on what was done over 100 years ago. So I think it's about, TB is a kind of sleeper disease. It's been with us for so long, people have got accustomed to it. And it's time that the people have to wake up and see the impact that it's causing globally.
And is this simply a matter of funding at this point?
I think it's certainly funding plays a significant role. I mean, when you look at the level of TB vaccine funding, 100 million a year is really pitiful. It's just not enough. But it's also about having the industry involvement at the earlier stage. I mean, we're very grateful to have both GSK and Sanofi involved in our development programs and taking candidates forward. But we don't really have any of the developing country vaccine manufacturers who are now playing an increasing role in providing vaccines for the developing world. And we don't really have biotech involved in terms of generating new candidates and feeding the pipeline. Out of the 15 current clinical candidates, 13 of them have come from Europe, only 2 have come from the US. So we have the immense powerhouse of innovation here in the US, and we're not doing enough here to develop the new candidates either.
David, give us a sense from GE's perspective. Where do you see the opportunity for you as a private company, a foundation, to come in and play a role? And are there areas also that you feel you could be doing things, but you're not really incented to do so at the moment? Different set of incentives might change your behavior.
Thank you, Matthew. So before I answer that, I do want to comment that I think that we talked about the SDGs and moving from the MDGs to the SDGs. 17 goals and 169 metrics is something I don't think any private sector entity would take on, trying to address 17 goals, and even in 15 years. It's a really complex thing to do, and it's really, I think, daunting to figure out how are you going to go after 169 metrics. So there's one side of me that wants to say, okay, we can tackle these one by one. There's another side of me, which is the way we're sort of oriented as a company, is to say, let's look at the whole system. And if you look at the whole system, that's just equally daunting. How do you begin to develop ecosystems in health and how do you begin to collaborate to address TB and HIV and non-communicable diseases. So I think our approach is to say, what can we do as a private sector, a large private sector company and foundation to have impact? Where do we have expertise, and where can we leverage that to be impactful? So for us, it's in health, it's in energy, it's in water, it's in education. And those, I think those 4 components can really drive a lot of impact in trying to address the SDGs. But the problem is, it's a big system, so you have to think about what you can do for simple interventions to have an impact on those 169 metrics. Which ones do you choose? How do you go after them? For us, our approach is partnerships. There's a lot of talk about public-private partnerships. I think we have to start thinking about not just public-private partnership, engage in the private sector, but I think the private sector itself has to start to partner together and figure out ways for us to work alongside Johnson & Johnson or non-healthcare companies and figure out how we collectively can take our different levels of expertise in different areas and then partner with the public sector to say, here's what we can do to offer. I don't think it's just funding, though. I mean, we can, as a foundation, we can provide funding. As a company, we can provide funding. I think it's expertise. We know how to, as I just said, we would never take on 17 goals. So can we bring that expertise of the private sector to say, let's simplify this. And let's not just simplify it, but let's start to act quickly and begin to do experiments that we can begin to address things.
Yeah, so we've got some examples of things that you've been doing that do seem to be models for the right approach.
We have lots of examples. One that I'll choose from a global health perspective is there's a very specific example. There's a tremendous lack of oxygen in sub-Saharan Africa, which affects maternal and child mortality dramatically. One of the #1 causes for child mortality is pneumonia. And one of the reasons for that mortality is there's no oxygen, especially in sub-Saharan Africa, but other parts of the developing world. And the reason for that, there are multiple reasons, but most of the oxygen is generated in the large cities. Most of the deaths are in rural areas. How do you get the oxygen from the large city out to a rural area? The roads are terrible. The cost of getting out there is tremendous. So what we did is, as a foundation, we did a project. We experimented, we piloted, and we built a oxygen generation plant at a district hospital level in Kenya and one in Rwanda. They generate oxygen for that hospital, saw the oxygen being used at that hospital, but they also fill tanks and distribute that out to the most rural health facilities, to the last mile, if you will. And now we're seeing the level of oxygen use go up. We're seeing the level of training of healthcare workers on how to use oxygen. And it's actually a revenue-generating model for the district hospital. They're selling the oxygen to the rural health facilities. So there's a place where we took a very complex problem, getting oxygen out to the last mile, and just did a simple intervention, tested it, see that it's working, and now what we need to do is figure out the next challenge, which is how to scale that.
So talk to us about that. How do you actually get from that pilot stage to the scale execution? Because that does seem to be such a common problem in a lot of these pilots you see around the world, and particularly in the developing world, that they never get any bigger.
I'll tell you the concept I'm trying to sell on this, which is that we believe as a foundation, we were the seed investors in this idea. What we need now are angel investors and venture capital level investors and then industrial investors to say, actually, this pilot idea really works. Let's bring it to the next level and to the next level and see if we can actually scale this. So it does come down to funding. I think the money is there, but it's trying to get funders to understand that this is an opportunity to make an impact. There'll be an opportunity to get a return, probably not venture capital level returns, but there is an opportunity to get a return on this. So we're at the stage now, we've demonstrated the model. We're out looking to see if there are partners again that we can engage in helping us to scale this.
Great. So I firstly want to, from your point of view, Deborah and Stefano, where do you see the opportunity to mobilize more private sector resources, and how do we go about doing that? I mean, you've heard examples like the oxygen example from GE, but what needs to change in the way governments spend and in the way the private, and what incentives do we need to offer to private players to actually do more?
Well, I think what we have done over the last 2 years is we have put out really clear challenges that we can all see quite clearly, like the issue of young women and young women's incidents. And instead of having private sectors coming to us and saying, we'd like to do this or we'd like to do that, we've gone out really proactively and said, this is a problem that I think collectively we can develop a solution to. So DREAMS is a public-private sector partnership. But it's not just about the money. And I think that's just such an important piece that was just discussed here. The innovation that the private sector brings that we need the branding of young women in the community changed. We want the community to value young women. So we want their brand to actually be increased. So you got to go to the brand managers. So we've gotten Nike now, Girl Effects, to really come with us about how they develop brands and how they develop a positive brand outlook. We've had Johnson and Gilead and Vive come with us on really how do we do innovative healthcare for young women, because the clinics that exist, which are really maternal child health clinics, are not clinics where a 16-year-old is going to go.
Now, are you dealing with their foundations and corporate social responsibility?
Both foundations and with the direct corporate links, because the corporate links really push us, again, not against the financial piece, but also about our big data pieces. We've got billions of data points that we want to visualize so that we can make changes within days and weeks, not months and years. And so bringing the data analytic skills and the visualization of that data so that the individual, we talk about the last mile for healthcare delivery, we've got to have the last mile for data usage so that the person that's in that clinic and taking care of that community can really see their impact and how they're doing compared to the other communities that are similar. So we have really, over the last 24 months, gotten really energized about what the private sector has been able to do and bring to us. And if we can tackle the issue of young women's education, brand, and cultural ability to inspire young women to see a different horizon, that changes everything that you put up there. The economic profile, it changes governance, it changes gender-based violence, it changes the ability of how a woman's viewed.
And is there anything that you've learned so far as to how is it you get the private sector to work with you in government better? What changed that made those companies?
We went out there with a concept of saying we want to impact HIV incidence in young women, because if the current rates of incidence occur, we're going to have 100 million HIV infections. And you just saw at lunch the demographic dividend that could exist in sub-Saharan Africa by that workforce and the economic growth. But if a third of them have HIV, as they do in Lesotho, Swaziland, South Africa, that's not a dividend. That's a real health drain to the entire economy. So I think the private sector really saw that that they had a unique talent that they could bring to us, because I think they want to be able to see themselves in the project also, so that, because they also want to sell brands to young women. So knowing what young women want helps Johnson & Johnson.
So I was talking to Ray Chambers the other week, the UN Secretary General Special Envoy on Public Health, and he's very interested in impact investing. How do we mobilize sort of purpose-driven investors? What role could pay for success bonds or social impact bonds play in kind of funding experimentations? So what do you think?
I think that when you, for example, ask a question about engaging the private sector, we've got to start by saying which private sector, because there are many private sectors that we would like engaged, right? So one of the issues, just to come back to the TB vaccine question, is in addition to funding Aeras to develop vaccines, which we need to do more of, how might we incentivize the private sector to get more into the business of developing vaccines, right? So one example of what the public sector can do is to say that if you produce a vaccine with these characteristics, I will guarantee to buy this much of it from you, and I will even guarantee to buy this much of it from you from the first person to get across the line, or the first two people to get across the line, or whatever. Having predictability and reduces the risk that you make an investment which is successful but not rewarded in the marketplace. So that's one example of working with the private sector.
And we've tried that a bit and finding some success there, or?
We have tried it a bit, but where we've tried it mostly is about incentivizing a reduction in unit costs so that people scale up to more efficient production processes and things of that sort. We have not tried it in a serious way for innovation of completely new product areas like TB vaccines. So that's one example of how, I mean, in the case of TB vaccines, the kind of collaboration that the Gates Foundation did with JP Morgan, where you come up with innovative financing mechanisms that de-risk late-stage trials and things like that, there are things that are being tried. I think,
do we know how that's doing so far?
Well, I think, all of these things I think are early. I don't think we have any major wins in terms of new product development, but I think there's lots of excitement. I mean, I think that program-related investments in the public sector in private companies is another really interesting area to incentivize the private sector. But I was using that as an introduction to what I think is the most important part of the private sector, which is implicitly what's behind what Debbie said, which is the public-private sector that is already serving and in the business of dealing with the problems that we're dealing with. So 75% of healthcare in India is delivered by the private sector, right? And so there, I think that what we need to think about is not necessarily how do we get the private sector involved, but how do we get value from the private sector that's there. So that, and I think there's fundamentally two approaches that you can think of for an approach like that. One is the one we take in this country, which is regulation. Just basically, I'm going to punish you if you don't meet certain standards. But the other one is, I'm going to incentivize you if you do meet certain standards, right? And the approach that many people are taking now is more like a franchise model, right? If you create providers that are certified quality providers, that gives them a competitive advantage in the marketplace. That's something the public sector can do, or even the not-for-profit sector can do, is to sort of give brand value to a quality set of the private sector and drive the expenditure in the private sector in a direction that creates value in health rather than just profit for, in the case of so much of private healthcare, unhelpful, the provision of private care. I mean, and we could go on to other sectors of the private sector and how to get them involved.
Can I make two comments about the private sector and kind of who we are, if I can be so bold as to speak for the entire private sector? I think there's a historical sense that the private sector is really commercially oriented. We have shareholders, we have fiduciary responsibility to our shareholders, et cetera. But I think there's been a sea change in the way the private sector thinks about itself in global health and global development in general. And the concept from Michael Porter of shared value is one terminology that you can use. There's a whole lot of other terminologies that you can use around the private sector, understanding now that our own investment in development will ultimately come back to us. And that if we invest in economic development, if we invest in health development with zero or little profit, that ultimately it's better for society and ultimately it will be better for us. So I just want to make sure that we really do all understand that for the most part, obviously there's outliers here, but for the most part, the private sector is really engaged in development and shared value and wanting to do good for the world. And yes, we have to have a fiduciary responsibility, but they have to go in parallel, and they do go in parallel. And it's not just us, I'll tell you this. We're talking to lots of other companies who have the same value set that we do, that it needs to be both. And then coming back to something that Debbie said a few minutes ago about innovation, we have to also think about innovation not just from a technology perspective. We're doing a lot of programs now around driving safe surgery and safe surgical ecosystems in sub-Saharan Africa and elsewhere. And one of the pillars that we're working on is innovation. And I've specifically said to our teams, don't think about technology. Think about business models, think about training models, think about delivery models, and be innovative there, and be innovative about the way you partner both with the other private sector players and public sector players as well. So I just want to make sure we don't think about innovation as just technology or data analytics, which we love, but it is all about modeling as well and how we do things differently.
And Jackie, do you want to stop David being the only spokesman for the entire private sector?
Just between the two of us, we'll talk for the private sector.
Well, it's quite ironic that the person talking about TB vaccines is up on stage coughing.
And I hope you're not coughing for that reason.
I'm hoping so too. And also just to comment, so Aeras is a not-for-profit organisation, but we partner with a large number of private sector organisations. And we're really dependent on them throughout the value chain, right away from the very beginning in terms of coming up with new vaccine discovery concepts, all the way through to market launch. But we're finding it increasingly hard to get them to invest time and effort in TB vaccines. I think in our colleagues and partners in the TB Alliance are also having similar issues around trying to get multinational companies interested in
So
TB
what could be done that would change the incentive structure?
I think it's about governments need to do more leading. They need to be making some investments in the basic science, and not just basic science, but also translational science. So I think governments could do more to lead. I think they could do more to incentivize the companies to invest in those areas. I think the various voucher systems, other incentives have been very helpful pull mechanisms towards late stage development, but we really don't have good tools to incentivize people at the early stage in discovery and in the initial valley of death. So how do we do that? I think WHO is starting to think about a new global fund for various research. I think other governments need to do more.
And David, what would you want to see more from government and other entities like foundations that could change the incentives?
In terms of incentives?
Yeah.
Well, I have to say my experience with the government engagement with the private sector has been very good. And so we look for that idea of partnership and sort of shared objectives and trying to identify places where governments are looking, as an example, for maternal and child health, governments are looking to have impact on pneumonia as an example. How can they reach to us and partner with us in getting towards that common objective? From a funding perspective, I think, yes, we can do the private sector can do some early investments, but I think ultimately the funding and the financing needs to be owned by government. And they need to understand that in the long run. That is, we're investing, I use Kenya as an example, not to point a finger to any one country, but as we do programs in Kenya, we're very clear that when the program comes to an end from our funding perspective and it's been successful, our expectation is that the government will pick up the continued funding for a sustainable program. But we have that conversation up front. We have that partnership development up front.
Is that a contractual commitment, more or less?
In essence, it is. In some cases, it's clearly in the MOU. In some cases, it's a handshake understanding. Clearly, everything's at risk when governments change. But the idea is that we're going to invest and start something. Our expectation is when it's successful, you will then take it on and carry it forward. Because we can't do it forever, right? We don't have the funds to be able to do that.
Let me add one more example that actually came from a colleague at J&J. The priority review voucher is an important one, which the FDA does, to incentivize investment. Imagine a similar voucher, but that gave companies the ability to extend the life of a patent by 1 year. The advantage of that one is that it's immediately convertible, and how much of an incentive that could be. And imagine if any country could offer that. So France could offer a 1-year extension on patent for things that met certain criteria. This would be a way of not having to have, a tax revenue funded incentive scheme, but the actual dollars that it would imply.
And what would that need in terms of international law changes to make that possible?
Well, in terms of commitments under international law is to respect the current duration. It doesn't mean that you can't provide additional duration. It means that you're respecting the TRIPS agreement. I don't believe the TRIPS agreement has any prohibition that a country deciding voluntarily to extend it an additional year for a particular product. And that could be a very powerful mechanism to incentivize investment in global health products.
Can I call up slide 51 again? I just wanted to talk in the last few minutes, one of the controversial aspects about the Sustainable Development Goals is that they are for rich countries as well as developing countries, and I think partly a lot of developing country leaders wanted the rich countries to be included because they wanted to end this development mindset that is in much of the public health discussion. And I think what's clear from our work on the Social Progress Index is that the curve does start to flatten as you go up the income level. It becomes harder and harder to deliver improvements as per capita income goes up. On base nutrition and basic medical care, the flattening is fairly gradual, but if we go to the next slide, 52, you will see on slide 52 that looks at higher levels of wellness and well-being. If we could have slide 52, please. you'll see that the flattening is pretty alarming. And I wanted to ask each of you, how do issues like obesity and mental health and so forth, are absolutely key challenges in the developed world. Is there a role for this international framework in actually pushing countries to do something significantly different, the rich countries to do something significantly different at home, or is this more a kind of tokenism for a symbolic thing for the developing world?
I'm finding it really resonates. So we've been reaching out recently to Black sororities, and you might say, why are you doing that? Because there's issues of gender-based violence on campuses, and there's issues of gender-based violences in communities in sub-Saharan Africa. And really seeing how we bring those two pieces together to tackle it. There's a mutual understanding that we're not coming in a development frame. We're coming in we've got a problem here, you have a problem there, let's share together of how we tackled it. It's the same way of young men of color in South LA, and their risk of HIV is related to their level of high school education. Same thing in sub-Saharan Africa with young women. So I think when we can draw those parallels, it allows us then to be solution finding that speaks to both. And I think this dialogue of learning and listening between developed and developing countries is really taking us to a very different place. We're learning a lot about wellness from sub-Saharan Africa as we look to really bring men into the healthcare system for the first time in sub-Saharan Africa, and saying, what incentives do you need as a male to want to come to the clinic to have your blood pressure checked, your diabetes checked, and by the way, HIV checked, because 80% is anywhere between 60 and 80% of the individuals on treatment in sub-Saharan Africa are women. So we obviously did really well there. We haven't done well with men. Many of those examples will apply to LA, Boston, and Miami, where we can really exchange about what are male drivers about wellness. So in the military, we used to call these dual use programs. You develop a microwave for a weapon system or a radar, and it was useful for something else. We really believe there's dual use between lessons that we can learn here through the SDG implementation and things that we can bring back here to make the United States above the curve in a whole series of areas.
And Stefano, the diseases of affluence, is there a sense that there's a global approach there?
Well, I think that we have a special problem in this country. I don't know of another country that's not at war that has increasing maternal mortality. So we have real issues in this country, and I think that to a large degree they're driven by the fact that we have levels of inequality that are unmatched.
So there's two separate issues. There's the pockets of third world poverty in wealthy countries like America that are growing, and then there's a second set of issues which relate to diseases that seem to be a product of affluence, like obesity and some mental health issues.
But ironically, in this country and increasingly in developing countries, obesity is a disease of poverty, not of affluence, because it's more linked to food insecurity. Obviously, if you have extraordinary levels of food insecurity, that's associated with being underweight. But in the time that I was in Mexico, the poorest 20% of the population went from being underweight to being significantly overweight, and has now surpassed the U.S. in terms of levels of overall obesity. So this issue of what are diseases of poverty, we think of hypertension and hypercholesterolemia and hyperlipidemia as diseases associated with wealth, because and now what we're seeing in many developing countries is the dual epidemic of the two. But I think when you look at this graph, which I think is more useful than the previous one in terms of thinking about high-income countries, you look at the U.S. there, which even though significantly richer per capita than Israel, has about 10 years less, or 10 less on your health and wellness index. So there are actually very large differences at similar levels of GDP, and figuring out what it is that we can do to learn the lessons from those who are performing better. And I'd go back, of course, to what I said before about disaggregating even more than this level.
I don't know if either of you want to come in on this point, or we can go to the final question.
I was just going to say, just to your point here, if you go down to the next level of this data and put figuratively sensors into the population, and we're willing to say the data is not perfect, but just do some analytics on it, I think you might get some clues as to why the U.S. is where it is, and Israel is where it is, and some of the other countries that you might not think would be where they are on this chart, why they're actually there. So I think we have to have a willingness to put these virtual sensors into the population and use whatever data we have and not overthink it, but just start to work on it to understand why we're seeing these dynamics.
Okay, we're pretty much out of time, so I wanted to ask each one of you just to end by saying, if there's one thing you want to see change above all in the next 12 months that will encourage you that we are starting to get to grips with the challenge that these SDGs pose us, what would be your number one priority for change? And start with you, Stefano.
I'm hoping that the federal government in this country starts to take global health and domestic health more seriously again.
I would say it's use of data down to the most granular level and ensure that everyone understands it. There's this tyranny of averages, and we lose the positive performers and we lose the negative performers, and we make everybody look good. And if we're really going to talk about health and wellness for all, we need to improve the negative performers and the mid performers up to the positive performers, but you can't do that unless you have that information down to that granular level.
Jackie?
For me, I think having bold dreams is very, very important, but I think you also have to have plans and solutions to deliver them. So I would like governments to commit more resources to basic and translational research to really enable us to meet some of the SDGs, because if we don't, we're just not going to get there. And it's outside of the normal political cycles, so something needs to change. Can't just be business as usual.
Last word to you, David.
Can I have 5? I guess if there's one priority, I'd say I think it's really, really important that we understand this is really complex, and the only way we're going to be successful is be willing to be bold, to choose some simple interventions, experiment on them, and leverage think outside the box in terms of the types of partnerships that you can leverage for these simple but bold interventions.
So give us one intervention you'd like to see happen in the next year that hasn't happened so far.
One simple intervention?
Mm-hmm.
That's a really good question. Well, first of all, I'd love to see what we can do around building ecosystems in each of these pockets that we're talking about, and not being afraid to actually build the ecosystem to deliver, in our case, safe surgery, in the case of maternal and child health, or in girls' education, to deliver a girls' education system that's actually going to work and be sustainable.
And can I just clarify that what I meant was the two sides of the aisle and the Congress working together. I said federal government, what I meant was the Congress.
Yeah.
Because we all work great.
No, but that was the wish that I was imagining.
Well, I think on that note, we should thank the panel for, we've obviously only been able to scratch the surface of an immensely rich and important subject, but I think the scratches we made have been useful and interesting ones. So I'd like to thank the panel for giving us plenty to think about, and I think we've got a lot more talking and hopefully action to follow from today. Thank you very much.
Thank you.
Ladies and gentlemen, please make your way to the next session, which will begin in 10 minutes.